Good morning, everyone. We are really excited today to have Professor Paola Romagnani from Florence present to us about podocytopathies. Professor Romagnani is the head of the medical department at the University Children's Hospital in Florence, as well as a full professor and chair of nephrology at the University of Florence. She did her residency in nephrology from the University of Florence and a PhD in endocrinology. And she has published over 250 papers in several high impact journals. She's got a lot of peer reviewed funding and several awards, including the ERA-EDTA Award for Outstanding Basic Science Contributions in 2020. So we are really excited to have her here today talk to us about personalized medicine for podocytopathies. Welcome.
Thank you very much. Thank you for the invitation. I'm very happy to be here because I think this is a very exciting time for nephrology in general, and particularly for the topic we are going to talk about today. And as you can see from the title of my talk, I think we are really starting an eve where we can think to address the problem of our patient with podocytopathy in a personalized manner. And I will try to show you the evidence that we have for that now. So podocytopathies are the diseases that affect the podocyte. The podocyte is an extremely sophisticated cell that is the crucial constituent of the glomerular filtration barrier, and that is the cell that decides, that controls the loss of the protein in the urine. That's why every time you have a patient with a proteinuria, you should always consider what is happening to the podocyte. Now, there are some basic information that we can discuss about these cells that seem to be basic research information, but in my view are very important to understand what's happening to the patient. The first thing is to know that the podocyte is a post-mitotic cell. So it's a cell that cannot divide, and there are biological reasons for this, because it has to control the glomerular filtration barrier in a very stable manner. It's continuously under a strong pressure that is comparable to the one of the Niagara Falls. And that's why the cytoskeleton is done in a manner that has to hold this pressure. And imagine if these cells would undergo mitosis and would divide in this condition, would not be able to hold the glomerular filtration barrier appropriately. So there are some cell cycle machinery controls that make it impossible for these cells to undergo mitosis. If this happens, the cell undergo an abnormal mitosis because doesn't have the machinery to do that, and dies in a process that is called catastrophic mitosis, and then gets lost in the urine. The loss in the urine is the crucial point that happens in all the patients that are affected by a podocytopathy, by a disease where there is a loss of podocyte. And the basis for understanding what happens in these patients is a seminal experiment that was made by Richard Wiggins around 20 years ago, where he deleted the different amount of podocytes in the glomerulus of a mouse using the diphtheria toxin. So he could know how many podocytes he had deleted and study the different lesions that he was observing in the glomerulus of the mouse in relation to the number of podocytes lost. He understood in this manner that when you have a loss of podocyte below the 20%, basically you have a picture that is the one of minimal change, because the glomerulus doesn't really change. Eventually, the minimum that you can see is a slight increase of the mesangial part, a slight mesangial expansion. Then between 20 and 40%, you start to develop a scar. So you start to develop focal segmental glomerulosclerosis. And then when you are above 40-50% of podocyte loss, you go to global glomerulosclerosis. So if one has understood this, has already clear a part of what is happening in our patients that lose podocyte and why in their kidney biopsy you can see this kind of lesion and what they really mean. But as I said, the podocyte is a cell that cannot undergo division, and so in this manner cannot replace itself when a neighbor cell is lost. But there is still some capacity to replace lost podocytes that is provided by the parietal epithelial cells of the Bowman capsule. The parietal epithelial cell is a simple cell, so still has a high capacity to divide, and can undergo migration and differentiation into podocytes from the vascular pole or through the Bowman space. When this process happens in postnatal life, well, happens in small kids, for example. We know very well that kids with in the first years of life increase their kidney dimension and also increase the glomerular dimension. And how this process happens, we know very well, recruiting new podocytes from the parietal epithelial cells of the Bowman capsule and increasing the size of the glomerulus. But this phenomenon can happen again also when you get an injury. For example, this parietal epithelial cell with this progenitor capacity for podocyte remain in the Bowman capsule even during adult life. And if you induce an injury, for example, here in the mouse, here the parietal epithelial progenitor are labeled in green, and you can see that they can migrate inside the tuft and acquire the podocyte phenotype, including expression of podocyte marker, including primary, secondary, and tertiary food process that you can see with high resolution microscopy. So obviously there is some capacity when you have a podocyte loss to get a replacement of the lost podocyte. But not always things go well. It can happen in whatever tissue or organ, even in the skin when you get a wound and there you have a stem cell that is very efficient and continuously divide. If the wound is very deep or if or too wide, or for example gets infected and doesn't immediately repair, you can develop a scar. And the same thing can happen in the glom. The reason are many why this process may not work, and there are many papers published that prove, for example, that proteinuria can impair, a severe proteinuria can impair this process of regeneration, because albumin in the Bowman space takes away many of the molecules that are needed to promote the differentiation process of parietal epithelial cell into podocyte, or mechanical forces like glomerular hypertension make this differentiation very difficult for the parietal epithelial cell. So basically we know that all these factors that we know well being associated with progression to chronic kidney disease of a podocyte lesion are frequently conditions that simply impair the differentiation of the podocyte, of the parietal epithelial cell into podocyte. And that's why then you can get FSGS, that is a scar. Now, if you look at things in this manner, you start to understand better what are these lesions that you see on the glom in the kidney biopsy of patients that have a podocyte injury. In minimal change disease, you are obviously seeing a glomerulus where the amount of podocyte lost is below the 20%, as Wiggins reported. And this can be below the 20% because it's a mild injury, or because, for example, you are a young person and you still have a kid, for example, and you still have a high capacity of generating new podocyte from the parietal epithelial cells, and then you keep this podocyte loss low. But if the podocyte loss is high or goes on for a lot of time, and it exceeds the capacity of replacement of the parietal epithelial cell, then you get a scar, a focal scar, and that's what FSGS is, a chronic injury that exceeds the capacity of regeneration of the glom. But there are other interesting lesions that can be easily explained if you look at things in this manner. For example, there is another variant of FSGS that is diffuse mesangial sclerosis. And this you see in small kids below the 5 years of age. And why these lesions, where you have mesangial expansion and then you have all these podocytes that appear one close to the other over the peripheral part of the tuft, like if they would be proliferating and dedifferentiating? Well, because as I said, below the 5 years of age, the capacity of parietal epithelial cell to generate new podocyte is really very high, and then keeps somehow this phenomenon going on at least for a while. And this is why this kind of lesion is observed particularly in kids that have genetic form of nephrotic syndromes and that are in the first 5 years of age, when this capacity of regeneration is very high. And then there is another lesion that is another variant, for example, of FSGS, that is the collapsing glomerulopathy, where we know that this is induced by massive proliferation of the parietal epithelial cells that and this happens usually when you have a massive podocyte injury in a short period of time. Then this is a stimulus for many parietal epithelial cells to start to divide and try to replace the podocyte. But since usually this is associated with an extremely high proteinuria, because you have a sudden loss of many podocytes at the same time, and you have a collapse of the glom, so that there is not anymore even the base where this parietal epithelial cell can migrate to differentiate, what you get is a proliferative massive lesions of undifferentiated cell, because this poor cell cannot differentiate into new podocyte in such a situation. So usually this is a lesion that you see in patients that develop a podocyte disease in a very fast, massive, and in a short period of time. So in this manner, you understand why we need to speak of podocytopathies and stop naming this disease with this term that we are used to see on the biopsy. I mean, don't take me wrong, the information that you get of the kind of lesion that you have is very important from the biopsy, but these are not diseases. These are pattern of injury. The diseases are better defined by this word, that is podocytopathy, because changes the way the damage occurs or it's handled by the progenitors, but the crucial point is the primary damage of the podocyte. Okay, there is another lesion that we can explain if we look at things in this manner, and this is the crescent. We now know, this is a paper that we published some years ago, that the crescent is a monoclonal lesion that is derived from the clonal proliferation of a progenitor cell of the Bowman capsule. And we then thought, when we saw this, that we could probably try to see if we could block the formation of the crescent by using drugs similar to the one that are used in other clonal diseases, like in the bone marrow. And that's what we did, using some drugs that are used for these purposes. And we identified particularly one that is panobinostat. This is a drug that was used for myeloma and other myoproliferative disorder. And we could see an improvement of the crescent formation in mice that were that had crescentic GN and that were treated with this drug. But the interesting thing was that this associated with the reduction of the formation of the crescent and an increase of differentiated parietal epithelial cells that were taking the shape of the podocytes. And what you were seeing was also that one was getting the glomerular filtration barrier somehow back. So the glomerulus was regenerated. Here you see a healthy 3D glom rebuilt with a staining with podocin with a high resolution microscopy. So what you see is the coverage of the glom of the podocytes. And then here a part has disappeared because it's a negative image where you get the crescent. And when you induce, again, the capacity of the progenitor cell to replace new podocyte, you get back the covered glomerulus, so where the glomerular filtration barrier is fully covered by podocytes. And what you can do with these fantastic new techniques with high resolution microscopy, you can really look at how the food process are. And you can see that in damaged podocyte, the food process get lost, becomes scarce, while they get reintegrated when you have redifferentiation of parietal epithelial cell into podocyte and replacement of lost podocytes. So somehow, why this is relevant? Because you understand that FSGS and crescent lesions are two faces, again, of the same phenomenon. In one case, you have a chronic lesion that follows a chronic podocyte loss and an inefficient attempt of replacement from the parietal epithelial cells that is not good enough. In the other case, you have a clonal proliferation of the parietal epithelial cell in response to necrosis of the glomerular filtration barrier and obliteration of the Bowman space. So it's an excess of expansion of the progenitor, but still, in both cases, the true problem is that the parietal epithelial cells cannot differentiate into a podocyte. So now, which is the concept of understanding what are these lesions? As I had anticipated, we know that these are not diseases. They are only pattern of injury. And this is very relevant to understand when you want to know how to treat appropriately your patient, because it's the lesion can overlap in patients that have the same etiology. For example, you can have minimal change or FSGS in patients that have genetic diseases, that have immune-mediated diseases, that have, okay, FSGS is much more frequent in the adaptive forms, but not exclusive if you do the biopsy very early, infections or toxic. So the etiology is the thing that you have to treat. The lesion pattern only helps you to increase the probability to understand which is the etiology. And that's why, in my view, we need a new classification, a new way of dealing with these diseases. And this has to follow the etiology of the disease and not the pattern of injury. In this way, we will know that we have adaptive forms where you have a problem of low nephron mass or nephron loss, or the patient hyperfiltrates for many possible reasons. You have genetic form, you have autoimmune form, and although these are much less likely, you have infectious or toxic forms. Okay, I will briefly go through the adaptive, the infectious and toxic forms to then focus on the two types of podocytopathies where the recent knowledge has increased and really changed the way we deal with the patient in the last years. So the adaptive forms, we know they have a problem of discrepancy between low nephron mass and or nephron loss and the hyperfiltration. So I always say to my students, it's a discrepancy between the capacity of the kidney and the request that you make to the kidney. Of course, we know that one, for example, of the main causes of adaptive form of FSGS is hyperfiltration. Now we know very well related to obesity, for example, but also diabetes somehow contributes to this type of mechanism by inducing hyperfiltration for the hyperglycemia. But then the other face of the coin is with how many nephrons you are born, because yes, the first development of the kidney ends at the 12th week of fetal life, but then we add nephron for all the pregnancy, and this adding nephrons ends only at the 36th week of pregnancy. And so we should know and always take into account that a kid that is born premature before the 36th week of age doesn't have the nephron, all the nephron that should have had. And the same is true, on this there are many data, for the kids that are born with a weight below 2.5 kilos at birth, even if they are not premature, because when you have a reduced arrival of nutrients somehow during the pregnancy, there is a shunt that brings the blood to the brain of the fetus. And so the kidney that normally takes a lot of blood during the nephron maturation reduces less and limits the nephron formation as a response. So a kid that is born underweight somehow is a kid that will have less nephron. The other point is we have an aging population, and so nephron loss is the other big problem, particularly when you are old, and that can go on top of other risk factor to generate an adaptive forms. Then there are infectious and toxic form. Infectious frequently give this collapsing picture that are associated, particularly, for example, with virus like HIV, EBV, parvovirus B19, SARS-CoV-2, that have a capacity to infect directly the podocyte. But these pictures of collapsing GN particularly happen in people that have also other risk factor, like, for example, APOL1 genetic risk allele, because this increases the local production of interferon that further enhances this loop of podocyte loss to make it become massive, and so stimulating this hyperproliferative response of parietal epithelial cells. And on the other hand, the toxic forms also have been observed in association with interferon treatment for similar reason, and other drugs like, for example, doxorubicin biphosphonate. But these are forms that are less important in comparison to the other of which I'm going to talk now, and these are the genetic forms. Here, we now know over 70 genes that can cause podocyte diseases. They are in large amount podocyte genes that control the cytoskeleton or transcription factors or the slit membrane, nucleoporins, many aspects of the podocyte function. What is important is that when you have a genetic problem in the podocyte, you develop a podocytopathy that is classically resistant to immunosuppressive therapy, steroids, and also immunosuppressant. And this now we know since several years. And that's why it's very important to suspect a genetic podocytopathies in those patients that don't respond to the first course of steroids. Podocyte genes are not the only type of genes that you can find in these patients. There are other type of genes that can mimic a podocytopathy. And this we now know is not rare in this type of patients. The most important of all is certainly collagen. Of course, having a mutated collagen makes the life of the podocyte hard because its substrate is not stable. So whatever condition that requires an increased work for the podocyte puts it at risk of detachment. And that's why, for example, collagen mutation are the most frequent mutation underlying focal segmental glomerulosclerosis in adult. But then, which are the patients on which that we should where we should do genetic testing when we have a proteinuria, particularly a severe proteinuria, a nephrotic syndrome, or anyway an isolated severe proteinuria? This was a question that we had for many years in our unit, because initially we were making genetic testing using whole exome sequencing to all the patients that had the severe nephrotic syndrome that we couldn't control with steroids. But then over time, we started to realize that there were really some clinical criteria that were predicting a high probability to get a genetic diagnosis positive. And that's why analyzing all our exome in a systematic manner, we concluded that when a patient has these 6 clinical features, a positive family history, an extrarenal involvement, a resistance to the treatment, or in case of other kidney diseases, which we are not discussing now, persistent metabolic abnormalities, at least 2 cysts at kidney ultrasound, and persistent nephrocalcinosis or hyperechoic kidney at ultrasound, we do genetic testing, and we usually use exome sequencing. So in the case of podocytopathy, the first 3 factors, the family history, the presence of extrarenal involvement, or the resistance to steroid or other immunosuppressive treatments, are the key criteria that we use for deciding for genetic testing. And then when you look in an unbiased manner to these patients, you realize that you can find a genetic cause in the 2/3, more or less, from 60%, from 60 to 70% of the patients have, when they have one of these criteria, have a genetic form of kidney disease. And the same, more or less, is true in the steroid-resistant nephrotic syndrome. And the fact of looking at the genetic testing, doing genetic testing using exome sequencing in an unbiased manner, makes us change the diagnosis in around 1/3 of the patients. And you can see that this starts to be really personalized assessment, because doing this genetic testing, you change many things for the patient. You can inform prognosis. Here we try to quantify in our cohort how much this had impacted our patients. And you see 1 out of 3 had information for the prognosis. 1 out of 4 had a cascade family member screening. Half had changed the surveillance of the disease based on that. In 1 out of 3, helped to choose the right treatment. In 1 out of 10 was important for kidney transplant implication. And in 1 out of 4 helped for reproductive counseling. So it was really, it's something that done in this manner somehow reduces the cost in a public system like ours, so can be easily handled, but has a big influence in the life of the patient. And then recently, there was another exciting discovery that I think opened completely a new way of dealing with our patients with podocytopathies. And this was the discovery of Astrid Wein's of anti-nephrin antibodies. This is the paper that was published in JASN not even 3 years ago, where she reported the presence of antibodies against the podocyte protein nephrin in around 1/3 of patients with minimal change disease. She studied also patients with recurrent form of FSGS after the kidney transplant, and could identify anti-nephrin antibodies in a part of these recurrent patients. But already in her paper, she reported that there were also many patients that had recurrence, but didn't have anti-nephrin antibodies. So when right after the paper came out, we started also to analyze our cohort of patients, and we looked in an unbiased manner at all the kidney biopsies that we had, and we did this with a particular technology that is high resolution microscopy. I don't know if you know about it, but anti-nephrin antibodies had already been reported by a couple of papers 25 years ago, using ELISA assay in the serum of the patients. But I think the true novelty, the big improvement brought by Astrid with her paper was really the assessment of this IgG in the kidney biopsy of the patients, which provided the proof that these antibodies really were attaching to the surface of the podocyte, and so were really somehow pathogenic. And to do this, she had to use high resolution microscopy, because if you go with routine immunofluorescence, you won't see this antibody. It's not sensitive enough, and that's why patients that have this autoantibody appear as completely negative, and that's why you have minimal change or FSGS definition, because you don't see IgG deposits or other immunoglobulin deposits at their kidney biopsy with immunofluorescence. But if you use high resolution microscopy, which is advanced confocal or even more sensitive type of microscopy like STED microscopy, you can see this IgG. And you can see here on the right what we saw in our cohort. We could see this antibody that you see as dots, yellow dots, in patients with minimal change and in patients with FSGS lesions. And to do this, we labeled the biopsy with an antibody against IgG and nephrin, and that's why in these patients they appeared yellow, because the IgG colocalized with nephrin. But while if you look at other type of kidney biopsy, you could see that the green and the red were in two different places, because eventually you can see the IgG depositions on the biopsy, but nephrin is another place, because these antibodies are not localized on the slit of the podocytes, for example, in IgA nephropathy or in membranous or in lupus nephritis or in collapsing GN. And it was impressively specific, because we could see these antibodies on the slit in around 1/3 of minimal change and FSGS patients, but not in other type of glomerulonephritis. So these are antibodies against the slit. But when we looked at these glomeruli with a type of microscopy with an even higher resolution capacity, like STED microscopy, where you can get at 50, 60 nanometers and still label with fluorescence your IgG and the nephrin, we could observe that indeed there were some of these patients where IgG fully colocalized with nephrin, and you could see the yellow because the red and the green completely overlapped. So this we could analyze even with specific software Here you can see the two peaks that are completely overlapped one on the other, the red peak and the green peak, which means that the two proteins are really in the same place. While there were other glomeruli where looked in a less sensitive manner, they could have appeared as colocalized. But then if you were looking carefully, these red and green were both on the slit, but not exactly in the same place. And here in this high power magnification, you can see it well. The red and the green are one close to the other, but not exactly in the same place. And even the peak analysis shows you that these are not perfectly on the same line, proving that they are not colocalized. So already this suggested that probably there were some patients that had antibodies that were not recognizing nephrin, but another protein of the slit. Then we did ELISA assay in the blood of our patients. This was a bit tricky, I have to say, and we needed quite some time to establish an assay that was working, using also peptide of different length, as is described in the paper. But what we could reproducibly confirm was that, yes, indeed, there were some patients of which we knew also that there were these antibodies on the biopsy that were positive for anti-nephrin antibodies in their serum. But there were patients that had this IgG on the slit and that we were not seeing that the IgG were localized exactly on nephrin, and they were negative also for anti-nephrin antibodies in the serum. So taken all together, this suggested us that, yes, there are autoantibodies against nephrin in some patients that have nephrotic syndrome or anyway severe proteinuria, but not all patients with IgG on the slit in kidney biopsy have anti-nephrin antibodies. There must be some that have antibodies against other protein of the slit. We repeated this data also in a cohort of adult patients. It's very interesting, the clinical analysis in these patients, in my view, because you can see that these are usually severely nephrotic patients. And even more interesting is if you start to look at the cohort, looking at also the genetic data that I had shown you before that we had for all these patients because they had all undergone exome sequencing. And particularly when we focused on our cohort of steroid-resistant nephrotic syndrome patients, we could see that there were two types of patients. Some had this autoantibody, and they were usually non-genetic patients, and the genetic patients with steroid-resistant nephrotic syndrome didn't have the antibodies on the slit. And this is the cohort of the steroid-resistant nephrotic syndrome patient, putting together the three informations. So you can see what I think is very important that comes out of this graph is that when you have a patient with a severe proteinuria, usually it's anti-slit protein positive or it's genetic. It's not that it's impossible to have this type of diagnosis also for a patient that has a lower proteinuria. It can happen, but it's considerably less likely. Obviously, when you have lower proteinuria, probably the adaptive forms become also very relevant and more frequent. But then the other important information that comes out from this analysis is that patients that have anti-slit antibodies, even when they are steroid resistant, then they respond to second-line immunosuppressant. While patients that are anti-slit negative, they usually don't respond to second-line immunosuppressant. So basically with anti-slit antibodies, you can distinguish which patients will benefit of second-line immunosuppressant from the very beginning. It was also very interesting that there was one case only of patients that had anti-slit antibodies and didn't undergo remission. And then I will tell you the story of this patient. That was a case of severe sudden onset nephrotic syndrome, resistant to multi-drug immunosuppression. We did genetic analysis in this patient, and we found a mutation in LMX1B the kid didn't have the classical feature of the syndrome that is associated with mutation in this gene, that is nail patella syndrome. It's a rare syndrome where you normally have abnormalities of the nail and the patella. The kid didn't have classical features, but when we found the mutation, we found also some subtle sign of the disease. For example, didn't have the runula of the nails, and upon X-ray, we found a bilateral lack of the epiphysis of the ossification nuclei of the elbow. We even recovered the renal progenitor cell carrying the mutation from his urine, and we could differentiate them into podocytes carrying the mutation and prove that indeed the cell obtained by this kid had the functional abnormalities, particularly in nephrin and podocin expression, because this is a transcription factor that controls production of nephrin and podocin in the podocyte. So we had no doubt that he had a genetic disease. The funny story was that the kid had a sudden onset and in 2 years went in dialysis without responding to any immunosuppressive treatment, while the father that was carrying the same mutation had a chronic proteinuria, but never ended in dialysis. Okay, so what happened to the kid when underwent a kidney transplantation? Had a relapse. And we could control the relapse with rituximab. Looking at the biopsy, he had anti-slit antibodies that appeared again during the relapse. So changing the kidney, the patient had become responsive to the immunosuppressive treatment, but obviously had also the anti-slit antibodies, and so had the relapse and responded to B-cell blocker. Okay, so having this information, as you can see, we can predict the outcome much better than the pathology pattern, not only the response to the treatment. We know that the anti-slit antibody patient, even when they are steroid resistant, they can go well, while the genetic one have the worst prognosis. And knowing which is the lesion pattern doesn't really inform you so well about how that patients will make. But then there is the final part of the story. So obviously, when we found that there could be also other antigen, we checked for other podocyte protein, and we could see that some of the patients that had anti-slit antibodies but not colocalizing with nephrin had instead antibodies against podocin. And this we could prove on the biopsy, but we could also show with specific ELISA assay in the serum of the same patients. And this really changes now how we deal with these patients. This is a patients that we recently had in my unit. It's an incredible story, and I think we could handle this only because we had this assay. It's a kid that arrived with a very severe nephrotic syndrome. We started treatment with steroid. The kid didn't respond to the steroid treatment. And then we did kidney biopsy. It came out a minimal change, but upon high resolution microscopy, as you can see, this kid had a colocalization between IgG and podocin, so suggesting antipodocin antibodies. Then we gave 2 doses of rituximab. We had a partial improvement of the proteinuria, but that lasted few, because the patients then had an upper airways infection and the proteinuria started to rise again. This infection became a pneumonia, and then the patient had an extremely severe worsening of the proteinuria with, I can tell you, also a phase of rapidly progressive GN that lasted 7-10 days during the pneumonia that was related to a chlamydia pneumonia infection. We did a second biopsy during this phase, and in the second biopsy, we had a proliferative GN, even with initial crescents. And there were some deposits of mild deposit, very mild, along the subepithelial space of IgG and C3. Okay, we couldn't treat the patients with the steroid because meanwhile, the patients had developed a very bad type 1 diabetes also. And and had resistant edema refractory to whatever treatment. But I had the antipodocin antibody assay, and here you can see in red how went the antibodies. And so I knew that this second episode had been associated with the sharp increase of the level of the antibody in the blood that had never really completely disappeared, even after the rituximab treatment. And so we decided to go with obinutuzumab, which is a decision that I would have never taken if I would have not had this serum. And this is how the story went after. We are still, what you see here are the results of last week. The kid that has completely recovered kidney function now has 0.3 of creatinine, and the proteinuria is quickly going down. All the exams are going back to normal, together with the antipodocin antibodies. So this is really personalized treatment of nephrotic syndrome. We found also another antibody that is more rare and that recognizes another protein, but this is in only 3 patients. The other protein is KIRL1. These data are already published. And I think the most interesting thing is the overview of our cohort of patients that were positive to anti-slit antibodies in the biopsy. And here you can see that, yes, many have nephrin, particularly when they are kids, but many have also antipodocin antibody. Anti-KIRL1 is more rare. There are still some patients that we don't know which is the antigen of the antibody we see deposited on the biopsy. So to conclude, I would like to say that podocytopathies nowadays should be treated in a different manner like we were used to do. We know now that definition like minimal change, FSGS, collapsing GN represent only pattern of injury and not diseases. We can identify patients that have genetic or autoimmune forms of podocytopathy and even combine the etiologies in a personalized manner. We can frequently now do this in a non-invasive manner because in some patients you can do it with a serum. We can personalize treatment and counseling to the families, and we can predict outcome in a much more personalized manner. And this is really the last 3-4 years. And so I conclude thanking all my collaborators. That work that you have seen here has been particularly important, the work of Valentina Raglianti for the anti-slit antibody. Maria Lucia Angelotti is our high expert and artist for high resolution microscopy. Letizia De Chiara established all the assays, the ELISA assays. Francesca Beccherucci is our genetic nephrologist, together with Viviana Palazzo and Samuela Landini for the genetic analysis. And I thank you for your attention.
Thank you for that wonderful presentation. It's truly a great time to be in nephrology and glomerular diseases after having little progress for the past several years. So if people have any questions, please raise your hand and ask questions. Oh, Chris.
Yeah, thanks, Swapnil. Thank you. That was an outstanding talk. Really enjoyed that. In terms of the anti-nephrin antibodies and the kind of the mechanism of injury of the podocyte, do you think that those antibodies are simply altering the intracellular signaling of nephrin, and so the podocyte is kind of reverting back to maybe a developmental stage or something along those lines?
Well, there are some reports that indeed demonstrate that there is an alteration of the tyrosine kinase signaling when there is the binding of the antibody to nephrin. I think it might really even only be a special problem. I mean, when you have antibodies that bind to nephrin, obviously the molecule has the functional site that is not able anymore to connect with the other molecule. Nephrin is such a crucial molecule for the filtration barrier that even a small amount of this antibody can really create a big problem to the protein filtration. And I think that that's probably one of the reasons why we needed so much time to discover these antibodies, because in our experience, the level of these anti-nephrin antibodies in the serum are small. So already a very small amount is pathogenic. And then imagine these patients develop an extremely severe nephrotic syndrome, which has the characteristic, particularly in kids, of a severe hypogammaglobulinemia. So the antibodies are quickly lost. And that's why a small amount, quick loss, they are difficult to detect. But, and that's why also the biopsy can be very helpful when you are not able to find them in the serum, simply because you arrive in this moment where they have already started to drop, having a level that is not so high. But I think that the story is probably even more interesting, because the same is not true with all these autoantibodies. The level of pathogenicity of the antibody may be different. So probably also the antigen will inform us a lot on how to behave with these patients.
And the Podocyte epitope, I guess, is there some exposure on the extracellular side so that those antibodies have access to it? Because I always thought of Podocyte as more intracellular.
Yeah, this we guessed the beginning when we found this. And we did many experiments to try to understand. Well, the portion of the antibody, the portion of the podocyte that is recognized by the antibody is mostly localized in this part that is transmembrane and in the lipid rafts. So you know that the lipid rafts are an extremely mobile structure of the membrane, and it's easily accessible for the antibodies. This we could do also flow cytometry experiments with cells that were completely intact and alive. And the antibody that recognizes this portion can see the podocyte on the surface. And then this becomes even more, even stronger for whatever factor that enhances the exposure, I mean, alteration of the glycocalyx or things like this. But it's already accessible on the surface of the cell because it's exactly this portion.
Thanks very much. That's great.
Thank you. Todd.
Can you hear me okay?
Yep.
Yeah, okay. Thanks again. I'll just echo what Dr. Kennedy said. Amazing talk. I've learned a huge amount. I guess two kind of questions coming from a clinician. The first with these anti-nephrin antibodies, how do they actually get to the slit diaphragm? You know, we don't think about antibodies as being something that does get filtered. They're too large, and so that would be one question. And then I guess the second observation is that, you know, the steroid responsive nephrotic syndrome patients respond so rapidly to steroids, often within a few days. Is this just that, you know, that injury is early, those podocytes, all they need is to regenerate that nephrin slit diaphragm connection, and they become, I guess, integral again, and that helps us? Does that observation help us understand the pathophysiology?
Yeah, very good question. I mean, I like a lot that as clinician, we all have the same question in front of this. Obviously, we also had this same question when we started to work on that. And I think of course, I can provide the answer I tried to give. I think we will need still some experiment to prove of some of these things directly. You know that these are IgG, and IgG pass from, we know it very well because we find them in the urine of the patients. So, of course, they reach the subepithelial space, and that's why we find them also in the, so when there is a bit of inflammation or damage to the membrane, the IgG pass. So usually there is an infectious trigger in these patients. And this with kids, you see very well. We see the peak of these anti-nephrin antibodies at 3-4 years of age. So there must be some kind of infection that this kid take that is the trigger of the production to these autoantibodies. And that probably also creates some kind of rehandling of the glycocalyx of the membrane or something like that, that makes this antibody pass onto the subepithelial space. So it's interesting the fact that this nephrin is a very particular molecule. It's a molecule that has a high homology with the immunoglobulin-like proteins, but not like whatever adhesion molecule that usually have the C1 portion of the immunoglobulin that is repeated. Nephrin has even the C2, which is specific only of protein of the immune system. So the T cell receptor, the immunoglobulin, and so on. And so I think this is a molecule that can classically give a molecular mimicry with some pathogen that probably we frequently meet when we are 3-4 years old. Maybe a bacterium, in my view, for example, a bacterial infection of the one that the kids take when they start to go to the primary school. And this way they do this antibody, probably the environment of the infection, LPS, create this first alteration to the surface of the barrier, make the IgG antibody pass on the other side. And that's how it goes. That's how I imagined it. We have several kids where we could prove that this first infectious episode was a bacterial infection, particularly a certain kind. Which was the second thing you asked me? I'm sorry, I forgot.
Just the rapidity in which some patients respond to steroid. Does the nephron molecule like regenerate quickly, or how does it work?
Yeah. That's a great question. Okay. Yes, I also guessed it a lot. It's well, my idea is that, as I said before, anti-nephrin antibodies are pathogenic at very small amount. So you really need few to make this antibody disappear, because you start to lose them when you have nephrotic syndrome and you develop hypogammaglobulinemia. And that's why I think probably of this fifth, now I speak of, for example, what I see with kids, because in adult the story is probably a bit different. But in kids where the anti-nephrin antibodies are frequent, probably what happens is that many of these kids have a transient autoimmunity. So they have the production of the autoantibody, like in a post-infectious GN. So they develop the antibody, this induces the damage to the barrier, then gets lost. And then if you have no further production of the antibody, and this, as I said, it's like in post-infectious GN. So in men, it goes like this. You have a single episode and nothing happens anymore. And so this disappears fast, and it can need only a very small amount of steroid that simply block the generation of new one, while the one that are already there disappear to end the story. The story is different, obviously, in patients that have the more complex form, that develop relapses and so on. But there we also know that the treatment is much more complicated, because probably these patients instead develop a memory, like you do with vaccination. The first episode, the titer disappear by itself. The patients that have the second immunization and that develop a memory, then they need more serious treatment. Usually don't make it only with the steroids, because they need a chronic treatment. The story becomes tricky, but I think also could be very exciting. We will see in the future, but I think it may a lot have to do not only with eventually delayed treatments or treatment that may not be the best one for that particular patient. I don't know, sometimes, for example, we start with mycophenolate, but the kid doesn't absorb well the drug, and then we need to move quickly to rituximab, because with that we don't make it. So, and the titer can remain high. I mean, there can be personal reason, but I think it may also have to do a lot with the antigen. Because what we see, for example, is that antipodocin is not that small amount of antinephrin, because connecting back to the question, the previous question, probably antipodocin antibodies are considerably less pathogenic than the antinephrin one. And so they have to reach higher level to become more pathogenic. And the patient develops the symptoms, the proteinuria, only when the titer are high. But then it's more difficult to bring down the titer. And you may need stronger immunosuppression. It's more likely that the patient has already developed the memory and it's B cell, and it's not a transient autoimmunity anymore. And this, I think, may happen also with other antigens that we still don't know. So I probably we will understand a lot in the next few years, and we will really have a clear picture of the heterogeneous behavior that this patient have, and why some basically undergo a very quick and spontaneous remission almost, or with a few, I mean, with a limited amount time of steroids, and then don't do nothing anymore, while others develop chronic forms, very difficult to treat.
Fantastic. Thank you again for these really informative and fascinating rounds. Classically we went from the bench to the bedside in the last hour, and for a really good Q&A. We are really excited for what's going to happen in this space. Thank you again.
Thank you very much, and thank you. Great questions.